Thank you, Prof. Mazuki. Can you hear me?
Yes, of course.
Okay, good. Thank you, Prof. Mazuki. In a nutshell, you have actually summarized what I want to say today in terms of the value of laboratory medicine and how we provide results to our clinical colleagues. Thank you so much for the kind introduction. I have known you for such a long time, and you are indeed one of the senior respected pathologists in our region. Thank you so much for the kind invitation.
Welcome.
And indeed, I would like to thank my friends, both Miswa and also Ibu Endang. They have been close colleagues of mine, and it's indeed my pleasure and my honor to speak today on this very important topic and just share some of my thoughts on the importance of how we can use some of new technology, particularly the informatics, in working through some of our requirements, which in the past were good to have, but now have become very essential. And of course, with the COVID situation, I do believe the value of the laboratory is unquestioned. Nobody can function in this situation without laboratory results. So I thank everyone for the invitation, and I begin my session today just by sharing that I am the president of a large federation within the region. This is the FRCPath, and Indonesia is a very important member, and Ibu Endang is the vice president of this very large grouping, the largest grouping within the IFCC. We are almost 40 years old. We've got very large membership, and we have billions of people in the area which we cover, and we are growing as many people are. Many of the countries which are still not captured, have shown interest in joining the APFCB. On the home front, many of you from Indonesia have visited Singapore, and I work in the hospital in the West. This is the National University Hospital. A few of the features are shown here. We are about 1,100 odd beds, and we run full comprehensive services for both adults as well as children. I want to start off by stating that no matter where we are, Indonesia, Singapore, some of the remote countries, we are in a position now where we can give good healthcare because of the connectivity and because of technology. And the breadth of healthcare equalizes healthcare, both in terms of geography, where you are in a big city, a metropolis, or in the remote country, as well as whether you have affordability or whether you are in a rural area. We need to give healthcare for everybody. And in terms of providing good healthcare, the National Electronic Health Record, this is the first of an important concept which I would like to share, meaning that patients' results must move across an integrated platform all the way from his own handphone or device for a person's individual results, right up to all his encounters in outpatient and inpatient experience, his allergies, his vaccinations, his lab results. Everything should be integrated into one common platform. And when a patient moves across different healthcare providers, his results are captured. It makes a very important case for us to have patient connectivity. And to do this, it's not easy. Everything from the patient's demographics to his identity must be captured correctly for the data to be input. Many of the lab results particularly need to be harmonized so that they can be compared, can be traced, can be tracked over a longitudinal time, particularly for chronic disease. And they must be populated into adequate electronic platforms. And the reason I say this is, if you look at a person's lifespan, we need to look at him from the time he's born to the time a person basically lives his entire life. that person will go through many aspects. Preventive care, where we want to make sure the person doesn't get into any problems, particularly chronic disease, lifestyle information. And then patient may go into a primary care setting, develop a complication, get involved in, say, major surgery in an acute tertiary institution, then recover and then get brought down to a community home, brought down to a rehab facility, and then from there towards home care. Now, this is going to be the model. Now, if we do not integrate this, you can imagine we're going to have chokes everywhere. And a very classical example is you have a patient with acute illness, but is unable to step down, say, following a stroke or a cerebrovascular accident, and the patient just occupies a bed. And we have a problem because we don't have a downstream rehab facility or a step-down facility. Now, if we don't do all this, the healthcare system is going to be problematic, and people who need the help do not get it. And of course, this is the term which we all know, and this is called right siting of care. The lab has a very important role in right siting of care. If we do not allow results, we do not allow the doctors the confidence to step down a patient, the patients will never be stepped down. So there are many aspects which we need to know, and the informatics is something which the lab is poised to fully exploit. Many countries have done so, Indonesia has done so, many of the cities is able to do this, but we've got a long way to go. Now this picture is nothing new, we all know this. Traditionally, lab practitioners have always defined the laboratory process as pre-analytical, analytical, and post-analytical. Today, I've been tasked to talk in this short period about the post-analytical phase. So I will quickly run into it and say that when we look at the post-analytical phase, we always have our doctors and stakeholders in mind. If you think about it, a doctor will order a test for a patient, and then he has no idea whether the test is progress or not. Has the patient gone to the phlebotomist? Did the patient listen to him? If the patient did go to the phlebotomist, has the sample been correctly picked up? Has it been sent to the lab? When can he see the result? The only thing which we need to do is to allow all these blind spots for the doctors to be aligned, and the doctor must be able to see, yes, I can see the result in such and such a time. And the electronics, the informatics of a completely connected system allows us to reassure our doctor that his order has been executed, is in the lab, has been resulted. If we do that, everybody will have confidence in the lab, the patient as well as the doctors and the caregivers. So we can do that, and we must always keep our eye on this. And in terms of the electronic flow, I've always maintained that there are two processes in the laboratory. One is the electronic process. A sample is ordered, it must be captured, there must be an electronic order trail all the way to resulting. Now, this is the E-trail, and it can be done when the doctor orders the test and done one time without the need for transcription, because that's the most effective and the safest way. The electronic process is then coupled with the physical process where a doctor orders a test. We then need to get a phlebotomist to draw the sample, to transfer the sample, to analyze the sample, and then to report the sample. Now, we always traditionally look at this as many pairs of hands doing it. But in reality, we do have the technology now to have a completely hands-free physical process, including robotic venipuncture. So you don't even need to have someone to draw the blood. The blood can be drawn, can be automatically labeled. You have conveyor belts to send it to the lab, full lab automation for the routine testing, and full result release, which means that both the physical process as well as the electronic process are completely hands-free in theory. Whether we see that sooner or later, someday it will happen. And lab staff will have value-added processes to ensure both the electronic and the physical process, end-to-end, are completely without flaw, completely rapid, efficient, to benefit our doctors and our patients. And I think this is a nice aspiration to have. Where we are in this journey depends on which country, which hospital, which location. But we move towards this journey and this aspiration, and then we will see it one day or another. In my hospital, I'm very blessed. I'm fortunate to have a lab, core lab like this, full automation. We've had this for about 15 years. And a picture like this allows us to show that many hospitals now have total lab automation. It's no longer a fancy novel piece. You know, the vendors have come in, many big companies put it down and say this is now standard of care. This is now expected, and this is now the solution which we all would insist on. Lab automation has many modules. It's not the topic of my discussion, but again, this is my interest. We've got, as you can see, pre-analytics, the input, centrifugation, all the aspects of analytics, and then the post-analytical. What goes into lab automation? In my opinion, 4 aspects. The physical aspect of sample handling, which is the track, the sample handling, the centrifugation, the decapping, the aliquot function, and then basically the stockyard. This is all the handling of the specimen. Then you've got the analytics to discuss. You need to know whether we are dealing with good analytical platforms which perform adequately. Then, very, very important is the informatics and the middleware. This is the topic today. We need to make sure that the information flows smartly and connected and allows a very seamless movement. We are dealing with high throughput, high capacity automation systems, and the middleware is important. Now, 1, 2, and 3, the track, the analytics, the middleware are very much dependent on the vendor. What we can do is we can learn from other hospitals about these 3, but the 4th process, your logic, your process, how you run your samples, how you define when they run is uniquely your own. Every hospital laboratory needs to go and customize their workflow to manage their own, their doctors, their culture, their patient movement, how quickly you do it, what you do. Those things are uniquely yours, and you pay full attention to how you customize your lab automation. Once you've got all 4 handled, you will provide very good service. Now, to use the informatics, I very quickly want to say that we've got multiple platforms, overlapping platforms. Analyzers have got onboard software. The automation have got track software. You have middleware platforms. You've got web-based platforms. You've got the LIS. You've got the HIS, which enters the patient's demographics. You've got the billing system, which many hospital administrators insist. In fact, billing is so important that, you know, many times we get forced to make sure that we bill correctly and all that, but that's part and parcel of reality, no choice. And then we've got the higher platforms, electronic medical record, where doctors want to see the record, national health record. So we've got plenty of platforms, many overlapping, many confusing, but the bottom line is they must talk. Handshake must be good, they must be robust, results, information must move in both directions to make it a very efficient system. So the functionality of a lot of this middleware covers many, many things. You know, we are so powerful that if you look even on onboard analyzer software, you will find many elements of this. Test management, sample management, quality management, equipment management, and even historical reports. I'll tell you about the historical reports, an important aspect where we can understand a patient's past history or past results to use it as a tool to see whether the current results make sense. So you've got many of these functionalities. Now, what do these middleware do? In case you want to list and you're not very familiar, look at the multiple aspects of informatics where a very smart lab professional would be able to exploit. You have software now which support everything from inventory control, automatic order, automatic delivery, to all sorts of complex workflow, to accreditation requirements on the ISO 15189, including, you know, measurement of uncertainty, QC reviews, customizable QC reports, etc., etc. And even if you look at the bottom bullet, when the main LIS goes down, when you've got a system downtime, you don't go completely paper because many of the software facilities in your system can act as a backup, can act as a mini alias, can hold your data until the system is up, and then you then upload. So there are many ways where you can exploit this. And I believe, informatics in the laboratory professional is a very powerful combination. I strongly encourage young lab professionals to take up lab informatics in a very big way. And this is where the future is for us. Now, in the post-analytical arena, now I want to go deep into this in the short time I have and quickly talk about the main topic, which I have in terms of the post-analytical aspect. How do we provide good resulting? And how do we provide results in a timely, accurate, and efficient way, as what Prof. Mazuki said? Now, this is the crux of it. Nobody reads a newspaper if it's yesterday's newspaper. Remember that. You can have a brand new crispy newspaper, hard copy now not so much hard copy anyway, but yesterday's news is no use. And the same with lab results. Do not give results which have got no more bearing to the patient's condition. It makes no difference. Give it real time, doctors act on it, patient benefits. Post-analytical clerical errors. This is number one on our list. Error, we cannot afford it. Patient pay a price, doctor pay a price. Ultimately, the lab pays a price when you have no confidence in the lab. And I've seen this, and I'm afraid I've seen this even in Indonesia years ago, where the doctors insist that the lab send somewhere else because there's no confidence. And this is the last thing the lab wants to do. Maximize lab automation, keep yourself hands-free. Maximize the interface, insist on bidirectional instrument interfacing, insist on a lab information management system, a LIMS, which is able to do that. Insist on where the errors can happen to be embedded into a systemic method. In other words, if you've got formulas, EGFR, basic lipid calculations, everything to be embedded in the LIMS so that you don't have to do manual formulas, and then regularly review to make sure that the formula hasn't skipped, hasn't jumped, and that we are providing good results. In all cases, make sure we do all of this. Now, you look at this picture which I've shown, and you look at the pie chart which shows the dwell time of a typical laboratory and how much time it takes from the time a sample is received to the time a sample is to a result delivery. And the pie chart just shows the allocation of time. Pre-analytics, before a sample is analyzed, is up to 40% of the time. Now, this is pure process. Sample receipt, sample documentation, sample order entry, then you spin, you aliquot, you run. If you don't have automation, you make mistakes because it's 100% process. Now, you look at the analytics. The analytics now is so powerful. Certain ISE in routine testing take 5% of the time, dwell time. Only 5% of the time in the lab is meant for analytics, and we can do it in seconds in many instances. Validation, 21%, reporting and result delivery can take a huge chunk of our time. And today I'm talking about auto-validation or validation. Now, auto-validation in real terms is the very last step a lab professional can intervene before a result is released. Remember that. This is the last step where you pick up any error, which could have been from a doctor order to poor quality sample, to poor analysis, to poor QC, to a calibration problem, an optics problem, a wrong calculation, whatever it is. Anything upstream is only able to be picked up at this stage. If you miss it at this stage, the patient then gets the wrong result. So be aware of this. Pay good attention to this powerful tool, which will allow us to catch as much of the problems we have upstream and also allow us to provide it in real time. If you do a manual validation and you are running like my lab, 4,000 tubes a day, each with 5 tests, and you are going to try and manually certify tens of thousands of results, it is desperately bad. you are going to make a mistake. You are never going to pick up samples or results which are meant to be picked up because there's just far too many. And the story about a needle in a haystack makes a lot of sense. Do not try and find one small needle in a big haystack. It's not going to work. Test verification can do all sorts of things. We know this. I'm not going to spend too much time because I think we are an informed audience. But I want to cover some areas which I myself have learned only recently about some of these auto-validation processes. When we do auto-validation, we've got two aspects of auto-validation. One is looking at specific aspects. Analyte specific, what test is being asked. We've got clinical auto-validation. We look at the demographics of the patient's diagnosis, comorbidities. We also look at technical validation, whether the run, the QC is in. And then if we have the benefit of previous data, as what I mentioned, we can do a delta check rule. Okay, now I'm going to go deep into this because I think this is new, important, and gives us capabilities which perhaps many labs do not unlock and do not exploit. Okay, in all of this, one aspect I want to learn and to explain to you all, learn to speak to our clinical colleagues. Do not be shy. Do not be afraid. Do not think that they call you only to scold you. They give you valuable feedback. They will give you clues about results which are not congruous with the clinical state, which suggest drift, poor results, for you then to have some idea and say, hey, maybe I should look at my results. They know. And the good doctors who give you good, valuable feedbacks, these are treasure for you. Do not dismiss them. Do not avoid them. Learn to speak to them. And the lab gets many, many insights. We get notice of our poor performance very early, before major disasters happen. Okay, so in terms of test verification, as I mentioned, we pay attention to the result, we pay attention to the instrument, the assay, the specimen, as well as certain patient factors. Okay, this you'll find in any textbook, and this is something which I want to quickly gloss over because I think there are more important lessons to learn now. This is an interesting algorithm. This is an interesting chart which shows perhaps some element which I want to quickly run through with you all, okay? Now, it may be a bit small, but look at it. This is a test which has been ordered in the top left. Let me try and get a pointer. Test which is ordered up here and to be completed, and this is where we call the auto-verification process. Okay, oops. All right, now, there are very systematic, logical steps for us to run through this process so that we can auto-verify the result, meaning the result flows through a system of Boolean logic. Logic means yes, no, yes, no. We build in the programs. If it's yes, it moves to the next box. If it's yes, it moves to the next box until all the criteria are met, then we can automatically release the result. The whole idea is to fine-tune all the Boolean logic such that we release perhaps 90 to 95% of our results and hold 5 to 10% of our results. These are what we call results which fall into our auto-validation queue. The auto-validation queue allows the technologist to focus on results which are questionable and which perhaps may have some problem. And now let's look at some of these criteria. This is a very simple delta check rule, which we all know. I think everyone practices this, or many people do. Very simple. You give a delta check, a value of a delta, a time frame, and then build this into a logic for delta check rules. But delta checks are flexible. Delta checks can be customized depending on how many results are actually trapped or captured and put on the validation queue. So we can look at it depending on the analyte, depending on experience. Okay, now beyond the delta check rule, I wanted to mention two other rules which are quite important and which can give you some clues. Okay, now beyond the delta check would be what we call a limit check rule. Now a limit check rule is a very simple rule which suggests that, look, there may be an absurd result, there may be a result which is completely wrong, which we need to hold. Okay, because we do see them and we do make sure that we do not release them, and these are quite simple to catch. And when we've got results which fall within our limit check, we then make sure we can try and do some troubleshooting. And this is then moved on to what we call consistency check. Now, this is a clever methodology. I want to spend some time because a consistency check is a logic which is built by the lab professional. Okay, now, a consistency check is very simple. If we ask ourselves, what can possibly go wrong with a sample? Beyond poor quality sample where we can pick up because of the serum indices, beyond poor performance because we can pick up by QC checks, but can a sample have other problems beyond analytical, beyond sample? Now, this is what the consistency check is all about. And this is very interesting. If we have potential problems, let's say I believe in my hospital, sequence of draw is not something which many of my phlebotomists and the people who draw understand. And there is a possibility of citrate contamination, EDTA contamination, heparin contamination, for example. I build logic. Very simple. If there is a possibility of citrate contamination, I have a certain pattern. For example, calcium and sodium. If I've got EDTA contamination, perhaps, it's calcium EDTA, so I got low calcium from EDTA and potassium EDTA and high potassium. And then for my thyroid screens, if I've got discordant results, if I've got patterns of, hormone movements between trophic hormones and, effector hormones, those things can be built into a logic, and you can then have a very, very rich set of rules, which looks at the consistency of the full range of tests. And this is now what I call the power, the value, the magic of an auto-validation logic. You build on it, it is a very valuable tool. The amount of layers which you can build is tremendous. And as I said, as you move along and you customize the auto-validation tool, the failures should be far and few. And these are the fail results which you then manually review, either go back to the drawing board or pick it up, correct it, and then release it. But this is the whole idea of a validation process which allows you to release a result in good time and with good accuracy. This is actually, in my opinion, the last check, the last frontier before we release a result. In terms of reporting, in the last few minutes, allow me to talk about critical results. This is where our doctors, our patients value our service the most. This is where time is important. This is where life and death matters. And in my hospital, we have been very lucky, blessed in many ways to have built a system. In this short time, I'll just give you the essence of the system. This is an automated critical result system which we use where we compile a list of critical results. Every hospital, every lab has critical results. So you compile a list, you have consensus with your doctors. If the result critical limit is too high, then not many patients get triggered. If it's too low, then too many, so your doctors may get a bit upset. So you need to compile a list and trigger it correctly. Glucose too high, too low, you want to call the doctor. Potassium, whatever, certain markers, particularly troponin for cardiacs and all that. So you compile a list. Make sure that we have all the aspects of who is to receive the result, what sort of communication, what sort of transmission, who is authorized to receive, which caregiver will receive, who acknowledges it, so that there is what we call loop closure. The lab gives the result, the lab acknowledges the receipt by a responsible person so that the patient benefits. Now, all these are now part and parcel of critical lab result SOPs. And as long as 20 over years ago, the Americans in the Institute of Medicine paper said that critical result reporting is one of a very important lapse in hospitals, where communication failure causes significant adverse reactions. So we need to do critical responses. And in my hospital, if you look at this, very simply, all I wanted to say is that when the LIS picks up a critical result, we built a software logic engine called the healthcare messaging system, and the logic auto-assembles a message from the various IT systems where your patient is, what his result is, what his diagnosis is, and they send an SMS to the doctor. Okay, very simply, the doctor picks up a message for a critical result. Hey, your patient in this ward, this bed with diabetes has got a very high sugar. And the doctor does very simple, acknowledges it and treats the patient very well. And you don't need to have a smartphone. Even this time you look at it, it was an old Nokia, not a smartphone, but allowed the doctor to respond. And we manage our patients sometimes as quickly as within 2 minutes of an auto-validated, auto-released result. So it is very, very fast, and technology allows us actually literally to do magic. Release it, allow the doctor to see it, and the doctor manages the patient straight away before any problems. And we build the rule because it's a logic, we build a rule. For example, biochemistry is easy. We can trigger high calcium, low calcium. We can trigger glucose. We can trigger now beyond the numerical values for hematology. You know, if it's total white is very high in a leukemic patient, significant anemia, we trigger. Even microbiology, we can trigger. TB smears, you know, you find acid fast bacilli, you got Gram stain positive. You know, a doctor straight away can actually tell, you know, and be aware of what the lab sees in real time. You know, we do routing between on-call, off-call doctors. We can trigger the entire team. So it is a very powerful critical alert system for which my hospital has actually won some American and even UK acknowledgements and awards. So we're very proud of it. It's been going on now for about 10 years, since 2011. So that's the result reporting in an acute situation. In a hospital context, we release routine results, we release critical results. And I want to end off today, before my time is up, by talking about an important facet of laboratory resulting. And this is where we change our practice now, where we have an aging population, increased chronic disease, difficulty for patients to now come to hospital, and for us now to pick up and to report on results in this changing environment. And this is the realm of telehealth, telemedicine, and the ability for us to monitor patients outside the hospital, the primary care or the clinic environment, within the home. And very quickly, I want to talk about resulting in terms of the telehealth cloud. We've got devices which we give some of our patients who have got 4 or 5 chronic disease. Patients with hypertension, patients with diabetes on a glucose meter, patient with anticoagulation on a PT-INR, and patient with heart failure, where they go and stand on a weighing scale to understand if they put on fluid weight over the last 24 hours in a person who's got decompensating or uncontrolled congestive cardiac failure. Now, all of these very simple devices, BP, blood glucose, blood pressure, and weighing scale, all of these are connected through a telehealth cloud, through a SIM card, and all these patients will have all of these measurements done in the house every day in a routine way, but the doctor, the pharmacist would be able to monitor real time. And if there's a problem with the blood pressure, even though a patient manages this at home, a pharmacist can call and say, hey sir, so-and-so, your blood pressure is high. I notice it. Did you take your medicine? Are you unwell? You know, same with heart failure. Are you breathless? Do you have swelling of your feet? Can you sleep well? Everything will be asked by somebody who's monitoring a patient back end. And this is the power of resulting and capturing a result through a connected system. You know, and I want to end off by saying that the informatics in the laboratory arena spans all aspects of diagnostics, from mobile health applications, you know, in real-time monitoring, to telehealth, to lab results, to electronic medical results in a hospital, to then electronic health results in a country-wide arena, and then we move on to big data analytics. Now, this is the next phase. This is where we analyze, we do predictive analytics, and we help to put resource into where we think the future of disease or disorders is going. And the biggest repository of data is laboratory data. And lab professionals must learn how to harness data, how to look at data, how to use it for artificial intelligence and for predictive analytics. And we are poised to do that. And the young ones, particularly in the Indonesian context, all you young lab professionals, go into sunrise areas, go into areas which will produce tremendous value, which will allow us to manage our patients in even a predictive manner. So I want to end, ladies and gentlemen, by just putting a few very broad conclusions that lab medicine will significantly benefit from modern technology, particularly informatics, and lab medicine will utilize a lot of digital health technologies to benefit individual persons and use it all the way for population type predictive analytics. We've got technologies, nanotechnologies, point of care technologies, and other technologies which will allow us to exploit ourselves. And lab medicine, in my opinion, will play a more and more important and influential role in patient outcome. And this has been clearly shown even in this current COVID pandemic, where without lab results, nothing can happen. So my final statement is lab medicine has a wonderfully bright future. We are poised with a future which looks exceedingly bright, but with it comes an exceedingly important responsibility. We are tasked to manage our patients, manage our clinical colleagues, to give them information. But with that, we need to do it well, we need to do it timely, and we do not have the luxury of making mistakes because the doctors and our patients cannot afford it. But overall, it is a very good profession to be in. And I wish I were many years younger where I can start and look at some of these things, which will influence our lives over the next 5, 10, 20 years. With that, I thank you very much. And, thank you again to all the organizers for giving me this chance to share some of my thoughts on this important aspect of the post-analytical result phase in our practice. Thank you very much. Bye-bye.
Maaf, Prof, suaranya belum keluar, Prof. Please unmute, Prof Marzuki, unmute.
Yeah, sorry. Thank you, Prof. Sethi, for your very important and essential lecture and also timely presentation. Yeah, as we talk about timely results, so you already give an example for timely presentation. Yeah. You have also already discussed a broad range of laboratory service and also, of course, stress to our topics, the post-analytical errors. You have given us some guidelines and tips. And you also already discussed about critical results routing and telehealth care in your hospitals. I would like to repeat your last statement of conclusion That's very important for our young staff, young members. Laboratory medicine has a very bright future. Yeah. So we should be happy, all of us. Thank you very much. And since this is a plenary session, there will be no question and answers. So I would like to give back the mic to our MC.